for sure. Um, so today is peripheral vascular disease, and also we're going to talk a little bit more in depth about hyperlipidemia, hypertriglyceridemia, in terms of people who have coronary artery disease or peripheral vascular disease. You guys touched upon this already in another class, right? PD
Oh, yeah.
lecture? Okay. So in terms of treating patients who are either high risk for plaque buildup anywhere in the body, or patients who have documented plaque in the body, we are much more aggressive with the goal LDL. So we just get a little bit into that because it is very relevant for prevention and treatment for any type of atherosclerosis. So that'll be like a brief couple of slides, and then we'll get into peripheral vascular pathology. So hyperlipidemia, there's a bunch of different categories. There's primary, secondary, mixed hyperlipidemia, isolated hyperglyceride. Why can't I? Hypertriglyceridemia. So this is kind of what we go by. These guidelines have changed like over the last 20 years a zillion times. These are the most recent ones. So the American Heart Association values go by these values. So total cholesterol that's over 240, LDL over 160, triglycerides over 200, HDL less than 40 in men or 50 in women. Primary familial hyperlipidemia. These are patients that have a genetic defect in their LDL receptor pathway. So usually this is a genetic component, and lifestyle modifications, weight loss, exercise, that's going to help them, but it's not going to be enough to prevent plaque buildup for them. This leads to premature plaque buildup, which we really care about. So how do we diagnose this? The LDL is going to be over 190, and then we're going to do genetic testing for, I call this the little LDL. Where is it? Here. The little LDL, ApoB, and PCSK9. Those are the receptor pathways that they are going to have problems with. Secondary hyperlipidemia, basically if anybody has a comorbidity that can raise their cholesterol levels, it's considered secondary hyperlipidemia, and you treat the problem first. So if they have out of control diabetes, you're going to really target that. If they have uncontrolled hypothyroidism, if they're obese, if they have metabolic syndrome, all those things you're going to treat and then see if they qualify for a statin therapy or a medication to lower their cholesterol. So primary familial hyperlipidemia, there's no other reason other than it's usually a genetic cause. And then secondary hyperlipidemia, there's another reason why they have something to raise their LDL levels. So that we need to differentiate too, because the treatment matters. There was actually a friend of mine, she was young, she had 2 kids, and she had familial hyperlipidemia. Usually these patients can present, like when you go to your primary care doctor and you're 18 and you have no other medical problems, they will have an LDL that's like 200. That's how these patients present because it's genetic, right? Even if you're young, healthy, and fit, it's a problem with the receptor pathway. And those patients need a statin regardless of what they're doing, diet, exercise, lifestyle. This is relevant to our patient population for patients that are high risk to develop plaque and have a coronary event, or patients who have documented plaque anywhere in the body. This could be they have a little carotid stenosis. We got a CAT scan. They had a little bit of plaque in the femoral artery. They have plaque on their coronary arteries. These are the patients we're going to be more aggressive with starting statin therapy. This is a nice little table that shows if you have established plaque, we start with a high intensity statin, and our goal LDL is less than 55. For the sake of keeping this clear, think if they have established plaque, you're going to want it as close to 55 as possible. If you have, let's see, I have to say, I will be completely honest with you guys, this is the first time I used AI to make a chart. And I don't know if this made it more difficult or less difficult if I just left it in bullets. So then there's primary prevention. So think everybody that has plaque, we want them as close to 55 as possible. For primary prevention, these are patients that we identify they're high risk of having plaque buildup, and we do that by using this risk assessment score. Have you guys seen that? Like the Framingham risk factor. You guys are going to see this in clinical life. So it's online or like an app, and you plug in their age, diabetes, sex, smoker, their cholesterol, blood pressure, and if they're treated for hypertension, the race, and it spits out a number. And it'll tell you the likelihood of that patient based on their risk factors having a coronary event in the next 10 years. And if it's over a certain percentage, you would start them on a statin in addition to lifestyle modifications from the jump. You don't have to have this criteria memorized. Even as a clinician, you're going to pull it up and punch in the numbers anyway. But you have to know that it exists, and this is how we risk stratify someone for having a cardiac event. Oops. Okay, here we go. You can also screen someone that has like a very high LDL with something called a CT calcium score. Have you guys heard of that? So just to reiterate, a CT calcium score is if someone presents as like a new patient to the cardiac clinic or primary care clinic, and you want to know how aggressive you should be with their statin therapy if they have high cholesterol and they don't have any documented plaque anywhere in the body. You can do a CT scan calcium score, and it's a certain protocol that takes a CAT scan of the chest and calculates how much plaque they have in the coronary arteries. It doesn't tell you specifics like if it's 90% blocked, whatever, 70% blockage. It'll just give you a score from like 0 to the thousands, and that will also give you how risky they are of having a cardiac event in the next 10 years as well. So that's how we determine how aggressive we're going to be with treatment, the Framingham risk calculator, and a CT calcium score can help us if we don't know if they have plaque buildup already. So that's how we kind of figure out how aggressive we're going to be. If they have diabetes and high cholesterol, we start them on a statin because that risk factor alone accelerates plaque buildup. So we're going to do lifestyle modifications, treat their diabetes aggressively, and start them on a statin. All of these scenarios make you more at risk of having some type of atherosclerotic event. So you're going to start with moderate to high intensity statins. So we're not going to do like a little lovastatin 10. We're going to like hit them with the Crestor 10. That's a higher intensity because we need to aggressively lower it.
For the CT calcium score, would that be useful for like the genetic causes? Like, would it take a while for the plaque to build up, or would you see it when they're younger?
That's a great question. So usually we wouldn't do a CT calcium score on like an 18-year-old. Someone presented like in their 30s and they have a strong family history of premature cardiac event, like in their 40s or something. You would do a CT calcium score could be helpful to see if they maybe need a stress test, right? Because if you have plaque, you want to see if it's causing problems to blood flow, and we do that by stressing the heart. So yes, but even if they have the genetic predisposition without the calcium score, you're going to start them on a statin anyway, but it would be part of the workup, definitely. Everyone good on this? The take home for this is if you have plaque, if you're high risk of getting plaque, you are going to start them on a moderate to high intensity statin. along with lifestyle modifications. We don't really give these patients, okay, well, let's lose weight, let's do your diet for like 3 to 6 months, and then we can repeat it. These are higher risk for dangerous cardiac events, so right off the bat, we'll start them on something. These are the categories for what's considered high and moderate intensity. Low intensity, like simvastatin, pravastatin, all these tavastatins, these we use if patients need to be on statins. We tried the moderate to high. They didn't tolerate it because they have like really bad muscle aches or they have rhabdo or they didn't tolerate it. We can start them on a lower intensity to put them on something. If someone's on the maximally tolerated statin therapy that they can be on, some people it's just pitavastatin because they get myalgias or GI upset or they have an allergy to something, and they either can't tolerate anything or they're on their maximally tolerated dose, and we're still not like close to 55 with the LDL, we can add one of these medications. So PCSK9 inhibitors are always approved, even for first line therapy for primary hyperlipidemia, right? Because they have a problem with the PCSK9 pathway. This directly treats that. So you guys have heard of like Praluent, Repatha. It's the injectable. It doesn't cause myalgia, so it's great in that way, and it very aggressively lowers LDL to a point that sometimes we've had patients that had an LDL of like 20 and we had to back off. So we love it for that. Azetum, I've never actually said that out loud. I've only typed it, but we call it Zetia. This you can use with a statin to lower it, and I put the little percentages. So PCSK9 inhibitors will lower the LDL an additional 60%. Zetia can lower the LDL an additional 18%. And bempedoic acid, this is newer, like in the last 5 to 10 years. This you can use with a statin and it will lower it about 20%. So this is in our toolbox if we start someone on a statin and we're not at goal. Any questions on that? Yep.
So for the primary hyperlipidemia, what would you do first?
You would put them on a statin, or you could do either one. It depends on their insurance. Usually insurance will cover a PCSK9 inhibitor, and all of these therapies, you are having a risk-benefit discussion. Sometimes you go through everything, all the results, and you tell the patient, you know, you really need to be on a statin for primary prevention of heart disease, etc. And they're like, my cousin almost died on a statin. There's absolutely no way I'm going to take a statin. And then you would offer that. So it's a discussion with the patient. You wouldn't be wrong either way, statin or PCSK9 inhibitor. Personally, I like PCSK9 inhibitors better because they don't really have any side effects. If somebody says, I absolutely don't want to do needles, I can't do needles, you try the statin first. What's like the worst thing that can happen with statin? What's going on when someone gets muscle ache on a statin? Rhabdomyolysis. So you can get, so the blood work we're checking before we put someone on a statin would be what? We would need BUN creatinine, we need LFTs, right? Because statins are metabolized through the liver. And when someone's on it, and if they say they're having myalgias, and it sounds like usually statin will have diffuse myalgias, not just like, oh, my wrist hurts. You can check a CPK or a CK. And if that's elevated, that's a clue that we're at the beginning of maybe this causing more problems with rhabdo. But if you have real rhabdomyolysis, your CPK is going to be like in the thousands. So that's something to think about when we start someone on statin therapy too. Yep.
How long do we do the statin therapy? Like, how long is our timeline to reach the goal until we consider like a second?
I would say usually we repeat it like in 3 months. Yeah. So 6 weeks to 3 months, we'll check it. Um, it really depends on the practice. Some people are more aggressive, but you can give them like 3 months on it and then repeat it. Great question. Anything else? So now for hypertriglyceridemia, we treat this a couple different ways depending on what is going on with the patient. So it's based on risk factors and how high the levels are. We're always doing lifestyle modification. This is the diet we want them to be on. If you can't remember what the exact diet is, less processed foods and sugars and carbs, and then the Mediterranean diet, right? So the fish, nuts, good fat, whole foods, whole grains, and regular exercise. And let's see. So if your levels are between 150 or just under 500 with no documented plaque, that,
That's in the basement.
that's still not us, right?
No, it's okay.
All right, you guys let me know. Um,
Still going. Bad.
okay.
Haven't gone to Happy Meal.
Maybe class. Yeah. Okay. All right. So no one's getting lunch, but we can continue the lecture. Okay. So if you have high levels in this range with no documented plaque, or risk factors to have a lot of plaque, we are going to. That's going to help us guide statin therapy versus lifestyle changes alone. So statins also treat triglycerides. So usually these patients will have elevated LDL as well, so they'll need to be on a statin, and that will also treat the triglycerides at the same time, along with all of these changes that you see over here. If your levels are 150 to just under 500 and you have plaque, you're definitely getting statin therapy, and you're also getting this isocaptid ethyl, which is just a prescription, very high dose of potent fish oil. Over-the-counter fish oil is not the same. It's not indicated, and studies have shown over-the-counter fish oil does not work. They need a prescription, and this will lower the triglycerides as well. If you have severe levels over 500, our main goal is preventing primary pancreatitis, right? Because over 500, you're at risk of causing pancreatitis. So we're going to do fenofibrate, and we're going to do the high dose fish oil and an extremely aggressively low fat diet, and then repeat the levels. Yep.
What kind of rating still plaque buildup? When would
So these people, you would do the risk assessment, like we did that like score that you plug in the risk. If they're low risk of having a cardiac event, you can wait to start the statin. You can counsel them and say, hey, the next step is going to be putting you on one of these medications, but we want, if you don't want to end up on the medication to treat this, we can do this over 3 months. We'll do like intensive change your diet, start regular exercise, and we'll repeat your levels in 3 months. And then if it's still high, you probably treat them with a statin. So these people, you can, depending on how risk they are, you can give them a shot at lifestyle changes alone first. These we're more aggressive with. Okay. So that's just like more details on specifically treating patients with statin therapy with documented plaque or high risk cardiac patients. Any other questions on that? Okay, so getting into the peripheral vascular system. In essence, this is just a sophisticated irrigation system supplied by the pumping power of the heart. So this is just a cool fun fact. There's 60,000 miles of vasculature in each human body. It's enough if we lined it up to circle the whole Earth twice. So that's how many veins and arteries we all have in our body at one time, which is like hurts your brain to think about a little bit. So that's what we're talking about today. We have blood continuously delivering nutrients and removing waste products in the local interstitial environment. Exchange occurs through the transcapillary system. As we know, right, it leaves the arteries, it applies oxygen and nutrients to whatever organ or whatever system needs it. And then through the transcapillary, it gets rid of the waste and the deoxygenated blood, and we go back up to the right side of the heart to the lungs to get oxygen again. Blood will always flow downhill from a higher pressure to a lower pressure, just like we've always known. The aorta is our main pipe. It's the largest artery in the body, and it carries blood directly from the heart to the circulatory system. Normal at the ascending aorta is 3 centimeters. 2.5 centimeters in the descending aorta, and the thoracic should be no more than 2 centimeters wide, right? In PD lab when we do our little finger testing in the abdomen. To reorient ourselves of what normal arterial anatomy looks like, we have our endothelium, which we talk about ad nauseum, our little single cell, hardworking inner lining of the vessel. Then we have the tunica intima, the smooth muscle cells in the tunica media, and then we have the tunica externa, which is the outside of the vessel. So what can go wrong? Number one, we're going to talk about aortic aneurysm. This is when part of the wall outpouches. It can have different shapes. It can be in different linings, if it's a true aneurysm or a pseudoaneurysm. So we can categorize these by depth. Like you guys can see here. Yeah. So this is a true aneurysm. A true aneurysm means that all of the layers that we just talked about are expanded. A false aneurysm or a pseudoaneurysm is when only the outer layer is outpouching and the intima and the media are not involved. So this is a false or a pseudoaneurysm. What's that?
Why does the sign say article?
Let me say for true. So only, oh, I'm sorry, only the intimal and medial layers are involved and they pop out of the outside.
The outside layer is fine.
The outside layer is intact. Thank you. This is commonly what you'll see, like if you, we would see pseudoaneurysms a lot if somebody had a cath and we needed to stick the femoral artery. Because you're breaking those layers and then removing it, it can cause the pseudoaneurysm, like a little sac, to come out. Thank you for that clarification. You can also categorize it by gross appearance. So fusiform is what we see here. This is the entire circumference of the vessel is enlarged. Saccular, this is more common in the aorta. Saccular is also a true aneurysm. Only a portion of the circumference is expanded, and this is more common in like cerebral aneurysms at the bifurcation of an artery. And then again, fusiform and saccular are true true aneurysms. And then we further define them by where they are. Ascending aneurysm, descending thoracic, and abdominal. Abdominal is the most common. And the etiology of how an aneurysm occurs is there's conditions that cause degradation or abnormal production of components in collagen elastin. So basically, anything that was like a risk factor to have plaque buildup in the arteries is also a risk factor to have an aneurysm because we're degrading the walls of the arteries over time. So smoking, age over 65, hypertension, hyperlipidemia, plaque buildup, male sex, and then connective tissue disorders genetically. So Marfan's, Loeys-Dietz, Ehlers-Danlos, hypertension, Turner syndrome, or having a bicuspid aortic valve. Certain types of vasculitis. So we're going to talk about that more in depth in a couple more slides, but inflammation of the vasculature over time, that chronic inflammation can lead to aneurysms. Things like giant cell arteritis, Takayasu arteritis, rheumatoid arthritis, all the itises are more at risk for having aneurysms in the vessels. And then less common in America, but TB and syphilis can also cause aneurysms. The risk of rupture increases with size, and that makes sense, right? If we're in water balloon season, so I don't know, I'm in mom mode, you can tell. I'm like, I don't know if everyone's like having water balloon parties and fights still, but when you fill up a water balloon, the more pressure, the bigger it gets, the more likely it is to burst. It's the same thing with aneurysms. The bigger the size, the more at risk they are for either a dissection or a rupture, which are life-threatening. The mean growth of aneurysms is usually 0.1 to 0.4 centimeters a year. It can be factor with connective tissue syndrome, so we monitor them more frequently than we would someone without those risk factors. A thoracic aneurysm, there's a 2% chance of annual rupture if the rate is less than, if the rupture rate, wait, what did I say here? Thoracic aneurysm, there's a 2% annual rupture rate if less than 5 centimeters, and then it increases to 7% if over 6 centimeters. Abdominal aneurysms, 0.3% is the annual rupture rate if it's under 4 centimeters, and then it jumps to 6.5 if it gets to 5 to 6 centimeters in diameter. So we want to monitor these patients to know how fast it's expanding, to refer them to a surgical team before it becomes a rupture, because it's an extremely high risk surgery with a very high mortality rate. And small aneurysms can still rupture. If they're smaller, it doesn't mean that they won't rupture. The risk is still there, it's just less.
Is there a difference between the fusiform and saccular? Like which one ruptures more?
That is a good question. I believe it depends on the size of it. Actually, I'm not 100% sure. I'll get back to you on that. Because you would think they're two different anatomical spots, but they're also usually found in different areas. Like the saccular is usually in the brain, and the fusiform is usually in the aorta. So I'll get back to you on that one. So presentations. This is one thing that I feel like students get confused on that I want to make a take-home point of. Aneurysms are usually asymptomatic unless they're so enlarged that you have like a pulsatile mass, or it's like in the ascending aorta and it's causing like dysphagia or like a pulsating sensation. It only really becomes symptomatic if it's dissecting or if it's ruptured. But usually the presentation of aortic aneurysms are incidental finding on screening, or maybe it's so enlarged that they have a pulsatile mass, but that won't be painful. Focal compression, like we said, they could have like difficulty swallowing or feeling like there's something stuck in their throat. A sense of fullness or throbbing in the back or epigastric area, if that's where the aneurysm is located. And sometimes we don't know patients had an aneurysm until they present as a rupture or a dissection. So that's also another reason why hypertension is called the silent killer, because it can cause aneurysms and it doesn't cause any pain until it's a big, big problem. How do we diagnose this? A CT with contrast is 100% sensitive. If the patient is stable, we repeat this every 6 to 12 months to monitor how big it's getting over time. You can do an MRI, obviously not in an acute setting. An ultrasound is 100% sensitive and usually the initial test or detection. Usually the ultrasound will be done at bedside if we suspect that somebody's having a rupture like now. And this is what it will look like on like a 3D CT scan imaging. And this is a fusiform abdominal aortic aneurysm. The treatment for asymptomatic cases, this is based on size and other medical conditions, right? If they have connective tissue disorders, the protocol and the management is completely different than somebody who we're just monitoring the size of the aortic aneurysm. Aggressive blood pressure is number one in everybody, right? We don't want these patients having a high pressure through an expanding water balloon that they have in their aorta. We want this blood pressure as low as we can get, under 120/80 for everybody. We're going to treat them with a statin. We're going to put them on an ACE and a beta blocker. Risk factor modification, all of those risk factors, smoking, uncontrolled high blood pressure, all the modifiable ones, we're going to treat those aggressively as well. And we're going to get serial imaging. It could be a CT scan or an ultrasound for these patients. Surgery is indicated in the following. If somebody has an ascending aorta over 5.5 centimeters, descending over 6, AAA over 5.5 in men and 5 centimeters in women. We also need to take into consideration the underlying conditions. So you guys don't have to memorize these guys here. Just know that we're more aggressive with these genetic factors. I do want you to know these up here. So if Marfan syndrome is over 5 centimeters, they get surgery in the ascending aorta. Bicuspid aortic valve in the ascending aorta, it's 4.5 centimeters. So it's much more aggressive than the general population. And all smaller aneurysms, we consider surgery that expanded greater than 1 centimeter over like a year's time. Screening for abdominal aortic aneurysms in males over 65 was associated with 35% decrease in mortality over 12 to 15 years. So we definitely are recommending routine screening on males over 65. They get an abdominal ultrasound to decrease that risk of, if they do have one, rupturing it. So let's see. Over 65 and a history of smoking. We definitely do an abdominal ultrasound. Surveillance is, depending on the size, would be every 3 years. If it's 3 to 3.9 centimeters. In men and women, it varies a little bit, and you can do it once a year. As it gets bigger, we decrease the screening to 6 months. And then for thoracic aortic aneurysm surveillance, there's no population-based screening on this. This is more based on genetic risk factors that we would screen someone to see if they have a thoracic aortic aneurysm. And these are the surgeries that there's a lot of surgeries to fix it. The 2 categories I want you guys to think about is open heart surgery, where they put someone on bypass, they clamp both sides of the aorta, resect where the aneurysm is, and then put a graft, suture in a new graft for the patient. For some abdominal aortic aneurysms, you can do this endovascularly, so you could do it in an interventional procedure where they do this through catheterization. It's less risky for patients who wouldn't tolerate an open procedure. It's almost like, think of a coronary stent. They just make a new pathway and exclude where the aneurysm is so that this isn't at risk isn't as at risk to rupture or dissect because this is where the blood is flowing instead of into this um, not as strong wall on this side. Okay, so an abdominal aortic aneurysm emergency. How do these present? If there's signs of expansion or impending rupture, you'll have sudden onset of severe back pain or lower abdominal pain radiating to the groin. You could have, if there is a rupture of a AAA, that's when you might have Gray-Turner sign or Cullen sign, right? That's the Cullen sign is ecchymosis on the umbilicus, Gray-Turner sign is on the flanks. And signs of retroperitoneal bleeding, not necessarily specific for a AAA. You can have that with any other type of bleeding, but it's usually ecchymosis on the back area. The triad that you have to know the board is going to ask you about is abdominal pain, hypotension, and a palpable pulsatile abdominal mass is a AAA rupture. And this is an emergent laparotomy. It's a very high-risk surgery. If you rupture your aorta, that has the highest pressure in the body other than the heart, and you are bleeding out at a very extremely high rate. So this is an emergency. Aortic dissections. This is when there's a tear in the intima and then blood flows through the media. So you can see it here. It creates a false lumen. So this is the media right here. This is the intima layer, and this dissected. And now there's blood flowing through the intima and the media, and it can continue, right? This is blood creating a new pathway down that layer. So it can go towards the coronary arteries and the aorta, or it can go down the descending aorta and into the thoracic aorta, abdominal aorta. And these we care about because if you guys see here, this is creating decreased blood flow through the aorta, right? It's on its own causing a narrowing in the aorta, which is going to cause decreased blood flow. So you guys have heard, this isn't the first time you're hearing Stanford type 1 and type 2, or yes?
No, what do you mean little?
Okay, cool. So just to review then, there's Stanford type A and type B. Type A is when the ascending aorta is involved. These you usually do surgery on. Why do we do surgery on these? Is because if it dissects down the ascending aorta, there is a greater chance of coronary involvement or involvement with the aorta. And if the coronaries aren't getting blood flow, everything's shutting down, right? If the heart's not getting blood flow, everything's going to be hypoperfused, and this is an emergency. So if the ascending aorta is involved, it's Stanford type A, we do surgery. If for type B, it's only the descending aorta is involved. So that is less acute because the coronaries are not involved. Also, these three arteries up here go to the brain. So the ascending aorta holds a lot of clout because we're perfusing the coronary arteries, we're perfusing the brain. Those are critical. That's why we do surgery on this one. The descending aorta happens after the subclavian here. So the brain and the arteries are protected. The kidneys may be damaged, but we can do something about that. So this type B, we don't always jump to surgery. It's not indicated. For both of these parties, we are aggressively lowering their blood pressure from the start. But type B is usually only medical management. Predisposing factors, same things like we've been saying, hypertension, uncontrolled, connective tissue disorders, trauma, coarctation of the aorta, plaque buildup, pregnancy because of the extra volume, or having a bicuspid aortic valve. Stanford type A The more risky one, unfortunately, is the more common one. This has involved the aortic arch proximal to the left subclavian. Death may occur within hours if we don't have blood flow to that area. Stanford type B involves the descending in the thoracic. This is DeBakey type 3. This involves the descending aorta distal to the left subclavian like we saw already. And then the DeBakey I didn't chat about, but DeBakey just categorized it into 1, 2, and 3. DeBakey type 1 involved basically the whole aorta. Like it's the ascending and descending, and type 2 is usually isolated to the ascending aorta. Yep.
The type 2 progress to a type 1, or is it just kind of?
It can. It really can go any way, either way. Rarely does the descending aorta progress into the ascending aorta. If it starts here, if you imagine the dissection, the blood is flowing this way anyway, right, with each contraction. So yes, it could continue to dissect downwards. But if the dissection starts here and the blood's flowing down, it's less likely. Good question. So you're definitely going to be asked this. You've definitely already heard this. Dissection, aortic dissections, sudden onset of severe tearing, ripping sensation in the chest or abdomen. Hypertension is commonly seen because usually these patients will have underlying uncontrolled high blood pressure. Loss of pulses, right? That makes sense because you can think of like the whole aorta stenosing because of that intima separating and narrowing the lumen of the aorta. So loss of pulses, difference in blood pressure in the limbs. Complications are dissections are prone to rupture. If a rupture occurs or if the dissection occurs and it's large enough to compress the heart, it can cause tamponade. If it progresses to the pericardium. An MI, if it progresses to the coronary, like we talked about, in Stanford type A. Occlusion of the aortic branches, so cerebral, spinal cord, anything that branches off the aorta can also dissect and be occluded. And distortion of the aortic annulus. So if it dissects into the aorta, the annulus of where the aorta sits, the aortic valve sits in the aorta can be distorted. And that's also a big problem. So how do we diagnose this? A stat multiplanar CT with contrast. Very low threshold to send a patient with high blood pressure and ripping chest pain to the CT scan. You'll never be faulted for sounding that alarm. Or sending them to the ED from the office. MRI TE are great imaging for chronic dissection, but not in an acute setting. So we're talking more about acute presentations, but sometimes patients can have a chronic dissection that's small, and we find it on random CT imaging when they come into the hospital for other things. Usually that doesn't need surgical intervention. We can manage that with medication. We may see a widened superior mediastinum on chest x-ray. You can see where all these arrows are. This is definitely bigger than the aortic arch is supposed to be, right? You guys can see this is definitely enlarged here. The EKG may be normal or it may show LVH if they have high blood pressure for a long time uncontrolled and they have changes to the ventricle. That might be a clue to say this guy has uncontrolled hypertension for a long time. It may show LVH on the EKG. Or it might be an acute MI if the dissection involves the coronary ostium. So this could show whatever type of MI based on which artery is involved. So if the RCA dissected, you can have a STEMI in the inferior leads. If the left main has dissected, you could have anteroseptal ST elevations on the EKG. So those are some findings you may see. Just to review, what's the criteria for LVH on an EKG? Left axis deviation, maybe.
Then at the right, the R wave and S wave thing.
Yes. Which leads, you're gonna. So it's
V1,
S in V1
and 6.
and R in V5 or V6. And how tall do they have to be combined?
35.
They're over 35 millimeters. Know that, just in case you see it somewhere.
So you're gonna ask it again.
No, I didn't say that. All right, so how do we treat this? As an emergency. Rapid treatment of lowering blood pressure and heart rate. So if this patient comes in and their blood pressure is 180 over 100, we're not letting them sit there. That's acutely worsening the dissection. So aggressive lowering of blood pressure to 100 over 120 and systolic and 60 to 70 heart rate. Some might argue even less than that. If it's less than that, we are okay. We're using labetalol and esmolol drip or nitroprusside. Nicardipine for those who can't tolerate a beta blocker, and morphine for pain, and then also it has mild blood pressure lowering effects as well. For type A, we're taking these patients to surgery as soon as possible. We will replace the aorta with the graft. If the coronaries and the aortic valves are involved, we're going to replace those and bypass that as well. We're stabilizing them and we're transferring if our facility does not have a skilled cardiothoracic team to do a big surgery like this. For type B, aggressive medical management. Pristine blood pressure control, as aggressive as you can be. Blood pressure and heart rate at the goal. If there's high risk features or evidence of malperfusion with the descending aorta, you can consider taking them to surgery, but that's only in specific cases. Post-op monitoring, you're going to get a follow-up CTA in 6 months and 12 months. And then if the repair is stable, we're going to do a yearly ultrasound on these patients to make sure that there's no other dissection or aneurysm forming around the graft that we put in or fixed. This is like a big boy procedure. This is one of the procedures used to fix Stanford type A if the aorta and the coronaries are involved. And basically, the patient's on bypass, obviously, they clamp the aorta and then they remove the whole aorta and the annulus of the aortic valve. They sew the aortic valve in. They put a graft where the aneurysm or dissection was, and they reattach the coronary arteries to that graft. And it serves as a brand new system for the patient. This is a big, big surgery with a high mortality rate. And this is what it looks like when it's done.
What's the life expectancy after they get that?
That is a good question. I'm going to follow up on that. So we have, hold on, let me write these down because I hate when I say I'm going to follow up and then I forget. So your question was, do the aneurysm, does one rupture faster?
I actually looked it up for, and it was saccular because it makes, I guess
It's
like one side. It's one side.
And
Yeah,
the pressure's in that one spot?
Yeah,
That makes sense.
yeah.
Okay, they're the best. Okay, your question, what's the mortality rate?
No, like how much longer? Like what's the life expectancy?
Life expectancy? Okay, let me pop this into open evidence. Do you guys use that? Open evidence? It's really good.
Is it free?
It's free if you have an MPI, so it will be free to you guys when you get your MPI. Or sometimes wherever you practice has up to date too. That's what we used to use before AI stuff. Hang on 1 second. Oh yeah, yes. Wow, it's pretty good. So the 10-year survival rate is 72 to 86%, depending on the indication and the patient population. So if you survive the surgery, you're in good shape.
Pretty good.
Yeah. Awesome. Someone else had a question?
Or do you go on like ECMO for the procedure?
So
How do you
ECMO,
bypass the heart?
yeah, that's a great question. And the answer is yes. So usually ECMO is different, it's more of a long-term solution for patients that are like palliative or waiting for a heart. Like you could be awake on ECMO, like in the ICU. Usually that's like a long-term patients in the ICU on ECMO. Bypass is usually specific to open heart procedures. Um, it's a slightly different machine, but it's the same concept. One is just used long term and one is used intra-op. But both of them are run by a perfusionist. Good question. Everyone else okay on this? Okay, so peripheral arterial disease. We talked at length about coronary artery disease. It's the same process that's happening. It's just in anywhere else that's not the brain or the coronaries. So this is stenosis or occlusion in the aorta or the arteries of the limbs. Causes, number one is atherosclerosis is the number one most common cause. Risk factors are the same as everything we talked about for coronary artery disease. It damages the vessel over time. Thrombosis, embolism, or vasculitis can also be a cause of peripheral arterial disease. Fibromuscular dysplasia is when it's a certain genetic process where fibrin is deposited in the vessels. It's not due to plaque buildup, but conceptually it's the same type of stenosis. Cystic adventitial disease, don't worry about those. Those are just like very rare causes of other things building up in the lumen that can narrow the vessels. They're very rare. Usually it's going to be plaque buildup. Or trauma can cause this. The primary sites, the most common sites are the aorta, the femoral popliteal area, or the tibial peroneal arteries. Fewer than 50% of patients with significant amount of plaque are symptomatic. So this we would find for screening because claudication doesn't usually develop. Claudication is what? Pain with walking relieved with rest caused by stenosis of the peripheral artery. Those symptoms won't usually develop unless there's severe plaque buildup. So usually like over 70%. Same as our coronary arteries, right? That's when blood flow is compromised, when the plaque buildup is over 70% blocking the lumen. General signs and symptoms can vary based on location. So if the lesion is high up, like in the femoral artery, they may have butt claudication. So when they walk, they'll get like a cramp but it'll be relieved with rest. They may, if the lesion is lower, like in a tibial artery, they may have pain in the foot, and then that's relieved with rest. So depending on where the lesion is, that's where their symptoms are going to manifest. It's not always the same every time. So like we said, intermittent claudication is the main symptom, pain, cramping, aching, numbness, or a sense of muscle fatigue. Worsens with exercise, improves with rest. The site depends on location, like we said. If there's rest symptoms, this is usually indicative of severe ischemia. Same as with coronaries, right? If someone's having rest pain, it's probably a more severe blockage than if it's worse with exertion, relieved with rest. We're gonna see on physical exam, decreased or absent pulses. We might have a bruit on exam. You know, when you listen to like the aorta, abdominal, you listen to the femorals for a bruit, you may hear you may hear turbulent blood flow, almost like a murmur in the arteries. And that could be suggestive that there's calcified plaque narrowing. That could be a clue on physical exam. Hair loss can be a sign of decreased perfusion. shiny skin, thickened nails, and cool to touch because there's not a lot of perfusion, pallor or cyanosis, depending on the severity. Ulcers and gangrene are a sign of critical limb ischemia. These are things we're going to look for on physical exam. When you elevate the legs, you're going to get pallor, and when you put the leg down, you're going to get rubor. I don't know. I feel like this class, I lose my English language, but it's up there, the spelling. How do we diagnose this? Usually by history and physical exam. So just like when we define angina with the patient, how far can you walk before you get this? How long has this been happening? Does it get better with rest? Can you climb the stairs? These are all the same questions we're going to use to determine how bad the claudication is. And physical exam findings. We check pulses on physical exam. We examine the legs to see if it's shiny, has hair loss. This is how we're going to diagnose it. We can also do non-invasive testing to clarify further if you're suspicious on it being severe and needing an intervention. We can use Doppler and ultrasound to see the blood flow to that area, or we can use something called the ankle brachial index. Have you heard of this? Yeah. So we use the blood pressure cuff and we monitor how fast the blood goes through the arteries, and then we score it. An ABI less than 0.9 is diagnostic of peripheral arterial disease. 0.9 to 1.4 is normal. So this can help you quantify how significant somebody's PAD is. And this is usually done in the office, and it's very non-invasive. Use blood pressure cuff. If we think that we have some critical limb ischemia or this is really severe, we may need to do an intervention. We have to clarify it. Like say we're seeing ulcers, we really can't feel a pulse on this foot. It's like extremely faint. The symptoms are very severe for the patient. We can get a CTA, an MRI, or a peripheral angiogram. If we are considering maybe we need to open something up for this patient, maybe they would benefit from that. The gold standard is the peripheral angiography. So just like when we take the patient to the cath lab, we're doing that, except we're going the other way, and we are doing a peripheral angiography. Usually they'll go in whatever leg you are doing the angiogram on, you'll go in from the opposite side and snake the guide wire and catheter down, inject contrast, and it'll light up all the arteries, and you see it the same way as you do on a cardiac angiogram. And that's also how you can treat it. You can put a stent in there, you can balloon it open, same as the cardiac stuff. Risk factor and lifestyle modification. Modification is treatment always for all of our patients. Smoking cessation, exercise, good foot hygiene to prevent ulcers. Optimal management of high cholesterol, so statin and PCSK9 inhibitors, and control of their hypertension, diabetes. So if somebody has an LDL of 100 and you just identified by a ankle brachial index that they have moderate to severe peripheral arterial disease, how would we treat their cholesterol? What would we do? LDL is 100. We'd start a statin for sure, right? And which statin would you pick? Moderate to high, exactly. So that would be like Crestor, Lipitor 80. Crestor is my personal favorite. I feel like people do better with it side effect wise. Simvastatin, you guys probably already heard. That one is like an older one. I find more myalgias on that one. But I wouldn't switch it if the patient's been on it for 100 years and tolerating it. So yes, these are our patients' aggressive statin therapy like we talked about. And say we started them on the highest dose of Crestor we can give them. And then we repeat their lab work in 3 months and their LDL is 75. What could we do? We can add on PSK9, Zetia to start, or a Nexletol. So, and then we would repeat it again. Excellent. We're treating that. So, number one, risk factor, cholesterol control, antithrombotic therapy. So, aspirin or Plavix. If they just got an angioplasty, you're getting dual antiplatelet therapy, same as when you put a stent in the artery. There's a recent recommendation of aspirin and Xarelto, a low dose 5 BID for severe peripheral arterial disease patients, reduced major vascular events, but it also increased the risk of bleeding. So this isn't treatment across the board. This would be adding Xarelto for a very specific patient population, like they have vascular disease everywhere. Maybe they've had multiple interventions. We add on Xarelto if they're not a high bleeding risk to try to treat that further. Letol, it's the generic name is Silostazol. This is for symptomatic relief. This really, I've had patients on this with moderate to severe peripheral arterial disease, and we put them on this, and it dilates the arteries, and they really get a lot of symptomatic relief from it.
They're on it a lot.
Usually they're always going to be on, if they haven't had an angioplasty, you're always going to have them be on either aspirin or Plavix. Same as coronary artery disease, right? We see that you get an aspirin. And then this could be for symptoms. And then revascularization, this is reserved for patients with debilitating or severely progressive symptoms. We're not intervening on everybody who has a 70% blockage because this is a risk. Even though it's a lower risk surgery, there is a risk of infection, something going wrong. So we really risk stratify the patient to see if they need it, or if there's evidence of critical limb ischemia. They have gangrene of the toe, if they have ulcers, if they have no pulses, we're taking them for surgery to open up what we can to prevent loss of limb. Because ultimately, what happens if you let PAD go for way too long and you chronically have decreased blood flow to, say, the foot? Necrosis, and then you have to amputate. So this is everything to prevent that, so the patient keeps their limb. Surgical interventions, there's open surgical procedures, there's bypass, where they literally make an incision and create a bypass with a vein that bypasses the stenotic lesion. It is a very bloody, invasive surgery, so not everybody can tolerate this. You send them to a vascular surgeon for an evaluation. You could also do a peripheral angioplasty, which is less invasive. And in the right candidate can be great. So you could see the plaque buildup. Looks exactly like the diagram we saw of when you put a stent in the coronary artery. You deploy a little balloon with a stent around it, inflate it, it sticks to the wall, you remove the catheter, and then they need to be on aspirin and Plavix for a year. And then sometimes you can drop one, sometimes you can't, depending on the lesion and the interventionalist. But just know dual antiplatelet if we did an intervention with a stent. Okay, any questions on that? Good. So acute arterial occlusion, think of this as like the STEMI of PAD. So STEMIs happen because a plaque breaks off or there's a thrombus that acutely occludes blood flow to the coronary artery. An acute arterial occlusion is an embolus that happens the same way, just in a different area of a vessel. So we would need an emboli large enough to occlude a proximal artery. These are almost always cardiac in origin. So AFib can actually cause this. Sometimes AFib can present if somebody has a big emboli and they present as an acute arterial occlusion, wherever that emboli lands. Sometimes it can be in the peripheral vascular system. This can happen post-MI in endocarditis, right? Remember our emboli with the bacteria on it can move. Atheromatous, so sometimes there's like a an atheromatous is like a big plaque in the aorta that builds up over time, and they're big. So, and they're also in a high pressure area, so they're at risk of something pulling off it and moving down. Aneurysms are prone to emboli because there's pooling of the blood in those areas. A paradoxical emboli, do you guys remember this one? What happens here? Or a PFO. So there's a communication between the venous and the arterial system. So that means think of somebody had DVT, right? That's a venous system. And there's some type of communication in the heart, whether it's a PFO, a VSD, some ASD, and there is right to left shunting. So the emboli moves from the right to the left and then causes an arterial occlusion. That's a paradoxical emboli. A thrombus is usually from something breaking off of a wall of plaque, a damaged endothelium. Remember like way back when we talked about atherosclerosis and there was that diagram where if the endothelium is damaged, there's plaque buildup underneath and then that can rupture and cause something to move downstream. That's a thrombus that's moving. And then grafts. So if someone has a venous graft, it's more likely to clot up. There's a bullet point up here for collaterals. The heart is amazing, and the vasculature is amazing, that if this happens chronically over time, the vessels grow its own blood supply around that lesion to bring blood supply to the area that needs it. But that's a chronic process. If there's an acute thrombus and critical limb ischemia, there's no time to grow new arteries. This happens if this process is happening slowly over time. The common femoral artery is the most common site that this will happen. This presentation we know would be sudden onset of limb pain with loss or decrease in distal pulses. This is a classic sign. To give an example, to just kind of paint a clinical picture for you guys, when I worked in interventional cardiology, one of our jobs post-op would be to check the pulses in the cath patients. So you go up through the femoral artery with a catheter, and then they either put a plug or a stitch, or we would have to hold manual pressure for 20 minutes on the patient to close it up. Be like sweating, but that's how you could close it. And then afterwards, you check their pulses every few hours in case they had some type of critical limb ischemia, in case that plug is occluding their whole artery. We would check their pulses. So if someone had a pulse in that leg before the procedure, we'd always check them before. Say they had like 2+ or Doppler pulses, you write it down, they get the procedure, you do your post-op management, and then you go to check the pulses again. And if you have no pulse, that could be a sign of acute arterial occlusion, and that's an emergency. So you'd also see the patient would be in pain. The leg may be pale, no pulse. They may not be able to move it. They may have numbness or tingling, or it may feel cold to them. The loss of light touch. So remember the cotton swabs in neuro? You would do that on them, they wouldn't feel it. We would get an immediate CTA or an angiogram. We can take them back to the lab if we're concerned that we need to fix it. It should be done in an operating room to not delay revascularization. So these patients, usually the interventionalist would take them back into the cath lab, shoot the leg again, and then they're already in there if they need to open it up. IV heparin needs to be started immediately to prevent any further clot aggregation or formation. And then we work up for the source of the embolism. If they just had a procedure, you kind of know that's probably it. But if this patient presents with an arterial occlusion, we'll go down the rabbit hole of, do they have AFib? Did this come from a plaque in a different spot? Do they have a thrombus in the heart that moved out? So you look for a reason why the embolus occurred. And then we revascularize if needed. Like we said, we can take them to back to the lab, or we could do a bypass or a thrombectomy or embolectomy where they stick a catheter in and they use suction to actually like remove the embolus out. Amputation is the last resort. You don't want to have to do that, but if they present late enough and there's already necrosis and there's no way to save it, you have to take the leg or whatever limb it is. And this is a surgical embolectomy. You can also do an embolectomy with a catheter as well. Any questions? Yeah.
Does it look similar to compartment syndrome?
Yes.
Like, how do you tell the difference?
So actually I have a funny story about that. My first year as a PA, there was a patient who we did a radial angiogram on, and it was our job to like go and check. And she had some swelling. So we were like putting ice packs on it, but I was like brand new PA, and she had pain. It was cold to touch, but I didn't realize she just had an ice pack on her hand from the nurse. And it was very swollen. She's like, I'm like, can you feel this? She's like, no. So I called whatever surgeon, and I'll never forget it because he was so mad. It was like a weekend, and he was like, I'm at the grocery store. I can't come in. Are you sure it's compartment syndrome? And I'm like, I can't take the chance. You have to come in. And he came in. He's like, this isn't compartment syndrome. You have to tell the patient to elevate it and put ice on it. I was like, okay. Enjoy the rest of your supermarket today. But it's tricky to tell the difference. Usually the story is going to tell you. So compartment syndrome is usually because they had like trauma or a broken bone, or some injury to like the interstitial space that's causing the decreased blood flow. So there'll just be like so much swelling if they were in like a motor vehicle accident or they just had some type of ORIF of something, and then that area is swelling so much, it can cause like decreased pulses, loss of sensation, cold to touch, but the insult will be different. This is usually a clot that's cardioembolic or a plaque coming off. They won't usually be like super swollen, and that's probably the differentiating factor along with the insult that's going to help you with the difference of that. And still always call the surgeon even if he is at the grocery store. Trust your gut. Okay, so leaving the big aorta, we're going to talk briefly about some extracranial and aortic arch pathology. This is mostly like when you guys get into neuro. And have you had neuro yet? That's their sort of?
No, not the real neuro.
Not the real neuro? Okay. So this is just, we're briefly going to talk about it. This is large extracranial artery plaque buildup, can be a common cause of stroke and are common in patients that have coronary artery disease, right? Because plaque doesn't discriminate. If you have plaque in one area, you probably have plaque in other areas, especially if we have 60,000 miles of vasculature. You probably might have a little sprinkle of plaque somewhere else. The most common spots in extracranial and aortic pathologies that you could have plaque are carotids, the internal carotids, the external carotids, vertebral, subclavian, and the brachiocephalic artery. A lot of these are asymptomatic because they are a chronic process and they can form collateral circulation if this becomes severe over time. Patients with severe carotid artery disease can be asymptomatic if this is the case, and we'd only really see it by screening. So carotid artery stenosis, we diagnose this primarily with an ultrasound of the carotids to quantify the degree of stenosis. This is the initial test. If you want to see it more clearly or you send them to a vascular surgeon or specialist, they may order a CTA, an MRI. This is when your physical exam comes in. If you hear a bruit, they may have carotid stenosis. And if this is the first time you're seeing the patient in the office, it's important to not skip that because that may be their only sign that they have plaque somewhere if this is their initial evaluation. Treatment, same way we treat plaque that we've been talking about forever. Aspirin, statin, we need to control high blood pressure, high cholesterol aggressively, and if they're smoking, aggressive smoking cessation if they're open to it. This is an ongoing debate whether or not you surgically intervene for asymptomatic cases. It's not like a clear, if they have symptoms, that's different. We're going to talk about that on the next slide. But if they're asymptomatic, the problem is the surgery for this, or if you do this like via angiogram, the major side effect is a stroke. So you are trying to prevent them from having a stroke and they're asymptomatic, but the surgery can cause a stroke. So this risk benefit really is reserved to vascular surgeons for asymptomatic cases. And that's really all I want you to know about that. So this is just citing a couple of recent trials that showed for asymptomatic patients, medical therapy alone was the same as if you did a carotid endarterectomy. So I don't know about you guys, but if I was a patient and medical versus surgical had the same outcome, I'm choosing to keep the neck closed and just manage with medical therapy alone. If somebody has symptomatic and greater than moderate stenosis, we can refer for revascularization surgery for carotid endarterectomy or a stent. But if we're primary care, we're referring to the vascular surgeon or the vascular team. And just to, I don't think I put the symptoms on there. So what are some symptoms you may have if you have severe carotid artery stenosis? Dizziness, totally. A symptom can also be a stroke or a TIA. That counts as a symptom. Vertigo from decreased blood flow. Those are the main ones. You could have syncope if it's severe enough, right? If there's no blood flow to the brain says, I need blood flow, let's pass out. So syncope could be a symptom of that. That's when your history taking skills would really make a difference on referring somebody to surgery or not. Another extracranial or aortic arch pathology is something called subclavian steal syndrome. Have you guys heard of this? So this is when the subclavian artery is stenosed by plaque or sometimes genetically. And this can cause a lower pressure gradient than the vertebral artery, causing reversal of flow from the vertebral into the subclavian artery. So there should be a higher pressure. If you guys look at this diagram right here, this subclavian artery is closer to the main aorta, right? So this should have a higher pressure than the vertebral artery. But if it's cinched right here, the pressure beyond this stenosis is lower than the vertebral artery. So the vertebral artery blood actually starts going back the opposite way. And you can get symptoms like lightheadedness, vertigo, syncope, drop attacks. Arm claudication is a big sign of subclavian steal syndrome. And significantly different blood pressure in each arm, greater than like 40 millimeters of mercury when you check both arms. This is like I mentioned before, something that can cause peripheral arterial disease is fibromuscular dysplasia. So you can see here, like the walls of the artery thickened, and specifically a sign for fibromuscular dysplasia is a string of beads on imaging. But that could be a cause of subclavian steal syndrome along with plaque buildup too. So that's how it presents. A lot of these cases are not severe enough to be symptomatic, thankfully, and we just manage them. If it's due to plaque buildup, we just manage the plaque. The etiology, like we said, could be plaque is the most common. The left side is greater than the right side presentation. Okay, trauma, we're not trauma. Fibromuscular dysplasia, like we just saw, this is a non-plaque buildup cause. Radiation-induced cancer patients, we're on the lookout for subclavian steal syndrome because radiation can cause this. Dialysis fistula, Takayasu arteritis, or giant cell arteritis. How do we diagnose this? Blood pressure difference in each arm. We get a CTA or an ultrasound. The angiogram is the gold standard to diagnosing this. So you would take them to the cath lab, shoot that area on x-ray with contrast, and you'd see it that way. We treat this mostly conservatively. Like I said, majority of these patients are asymptomatic. It doesn't get to a point where they have like reversal of the vertebral blood flow or arm claudication. But for symptomatic cases, you can do stenting, you could do a bypass, open procedure, and of course, we're always treating the underlying plaque with medications that are, which ones? Statin, aspirin, those are the main ones, and beta blocker, mostly for coronary artery disease, but definitely aspirin, statin, we're treating plaque, and all of their underlying risk factors for plaque. Briefly, we're going to talk about arteriovenous malformations, or AVMs. These are usually more commonly found in the brain, so you guys are going to talk about this more when you get to neurology. But they can present anywhere in the body. And these are just abnormal direct connections between arteries and veins that bypass the normal intervening transcapillary system. They kind of form like a tangled blob of arteries and veins, which isn't what we want blood flow to be doing in a healthy way. So there's a high pressure arterial blood shunt directly into the venous outflow system, and this can compromise the vasculature's integrity. So a lot of AVMs are commonly found in the brain, and that could be a cause of like a hemorrhagic stroke if these burst. So they can occur virtually anywhere. 50% of them are in the head and neck, which you guys are going to get more into when you take neurology. They're usually associated with genetic mutations. Brain AVMs present with intracranial headache. Could be headaches, seizures, or just an incidental finding if they're getting a scan of their head for another reason. To diagnose these, you can do a CTA or an MRA. You need the angiography, right? We need the contrast because it's a vessel. When you guys think of imaging for anything peripheral vascular, that's a scan, the CT or an MRI is always going to be with contrast. Yep.
Even if these don't burst, would the tissue in the area be adequately perfused, or is because the blood is going through so quickly that it could?
Excellent question, and it depends. So sometimes yes, sometimes no. It depends on the severity and the location. There's like whole specialists dedicated to treating types of AVMs. Certain interventionalists like that would do cath procedures or specialize in peripheral cath. There's very in-depth criteria of whether you need to intervene or not. And one of the criteria is if it's obstructing blood flow or if it's a certain size or causing symptoms in the patient. And in those cases, you could do an angiography to like, I think they literally called it like a glue, and they like seal off the AVM or use something to break it down. But not all of them need it. It depends on the size, the severity, if it's causing any problems, but that's like a super specialized field for intervention. Good question. The treatment, observation, embolization, or take it out. So cardiac-wise, know that these can present in any organ system. Something that I wanted to add here that I want you guys to know that I want you guys to write down is something called Hyde syndrome. Has anybody heard of that? HEYDE'. So this is a triad of severe aortic stenosis, von Willebrand's disease, and gastric AVMs. And this is a syndrome that kind of perpetuates on itself. So if someone has von Willebrand's disease, the severe aortic stenosis does something to the abnormality in the blood with von Willebrand's disease that like causes the gastric AVMs. They're not totally sure the pathway, but it's highly associated. And if you identify somebody with severe AS, and they had like multiple GI bleeds, you may want to test them for like von Willebrand's disease or something like that because of that triad. And they're very tricky to treat because the treatment for severe aortic stenosis, if you need to replace it, you have to be on aspirin and Plavix. And if you have gastric AVMs that bleed a lot and a bleeding disorder, you're in a tight spot. So these are tough patients to treat, but definitely keep that on your radar clinically. All the other AVMs, mostly cerebral, you're going to see in neuro. What's that? Severe aortic stenosis, von Willebrand disease, gastric AVMs. And then I think we're almost done. So we're going to talk a little bit about vasculitic syndromes. So this is inflammation and damage to a blood vessel and associated with ischemia of the tissue supplied. So this is stenosis of the vessel, not caused by plaque buildup. It's caused by inflammation of the vessel itself that causes the narrowing of the lumen. So we treat this different than our usual plaque buildup patients. There's a very broad group of syndromes that can involve any vessel of any size in any location. Primary vasculitic syndromes are things like giant cell arteritis and Takayasu arteritis. Secondary vasculitis syndromes are a symptom you can get from certain drugs or another autoimmune syndrome like RA lupus. The symptoms will vary based on which artery is affected. So you can see Takayasu arteritis, giant cell usually involve the large arteries. Kawasaki disease is the medium vessels. Small vessel diseases are a lot of different type of autoimmune diseases. I don't expect you guys to memorize these, but I do want you to know large, medium. Yes. So giant cell arteritis is also known as temporal arteritis. And you guys saw this already in PD lab? Maybe? No. Okay, well, we'll talk about it. So giant cell arteritis is this can present anywhere. Commonly, it presents in medium to large artery, usually in the temporal and facial vessels. So the temporal artery gets very inflamed and stenotic, and that can cause certain symptoms, like retinal ischemia, a temporal severe headache. It's sometimes associated with polymyalgia rheumatica, jaw claudication, right? If the facial artery is involved, it can present as jaw claudication. Those are the main things. So think temporal headache, jaw claudication, and we diagnose this with a ultrasound. This is common in the cranial vessels or the aortic arch in females over 50. That you also may have a diminished temporal pulse because of that inflammation, and it's going to be extremely tender, even if you lightly touch on the temporal artery. The ESR-CRP, non-specific inflammatory markers are going to be elevated. We're going to do an ultrasound with Doppler. We may see a diminished temporal pulse. If that is usually enough to start treatment, but if this is part of like a bigger clinical picture and you really want to make a confirmatory diagnosis, you could take a biopsy, and that is how you can confirm. It'll show multinucleated giant cells on pathology. The treatment for this is high-dose steroids to decrease the inflammation and open up the lumen again. Takayasu arteritis. Usually this is more chronic in nature. This is like a slower progression. This commonly involves the aorta and its branches, primarily in females aged 10 to 40 of Asian descent. The signs and symptoms, this will be a pulseless disease. So wherever the lesion is, you will not have a pulse distal to that. You may have a bruit if you're listening over the affected part where the stenosis is occurring. You may have a fever, night sweats, malaise, and arthralgias and weight loss. How do we diagnose this? Characteristic post-stenotic dilation on angiography. Ultimately, you're going to take a biopsy to make the diagnosis. So you can see here, so the post-stenotic dilation. If you guys, can you see this right here? This is stenosis, and then there's post-stenotic dilation of the artery. So it's like stenosed in this one area, and then it dilates out again. That's characteristic on angiogram. We treat this with steroids, immunosuppressants, and surgical bypass if needed. Thromboangiitis obliterans, also known as Berger's disease. This is caused by severe vasoconstriction caused by smoking. That's it. Once you stop smoking, it stops. Usually this happens in males under 40 that are smokers with Middle East descent. Triad of symptoms are distal arterial occlusion, Raynaud's phenomenon, migrating superficial vein thrombophlebitis. So they'll have like superficial inflammation of the like superficial veins in different spots at different times. There's not going to be plaque buildup. It's only caused by inappropriate vasoconstriction. Treatment is stop smoking. I saw a case, this is very difficult in patients with severe addiction. We had a patient in the hospital with this. All of her fingers had to be amputated everywhere. She still smoked. Yeah. So it's very difficult to treat like a true addiction. Like this.
She was holding like that. Wow.
I'll never forget her. And now you'll never forget Berger's disease. So it's only from smoking. Yep.
Isn't this like this male stuff?
Yeah. She was a female.
She didn't have.
What'd you say?
She had.
Yeah, she had this.
Oh.
Yeah, but it is mostly males. So it's mostly males, but when we say mostly males, it doesn't mean like it's impossible, just like the common demographic. Raynaud's phenomenon, this is digital artery spasm, triggered by cold or emotional stress. This is inappropriate vasoconstriction. You'll get it's an exaggerated sympathetic response, common in women to 20 to 40. But to your point, my husband has Raynaud's, so he's the outlier in this demographic. Secondary causes, this can be associated with other autoimmune disease like lupus scleroderma. There's a disrupted endothelium in those cases and excessive vasoconstriction. You'll usually have the triphasic color changes. So they will experience the cold or emotional stress. The fingers will go from blue to pale to red. And it's painful and you'll get tingling with it. The treatment is avoid cold and stress. And if it's severe enough, you can treat this with a calcium channel blocker that helps with the inappropriate vasoconstriction. Now we're going to talk a little bit about the venous system. This is the venous system, just to review anatomically for you guys. A common pathology in the veins are varicose veins and chronic insufficiency. Usually these will commonly go hand in hand. They don't have to present together. They're caused by dilated, tortuous, superficial vessels in the lower extremities, more common in women than men. Primarily, you're going to see this in the superficial veins. This can happen from prolonged standing, pregnancy or obesity, there's extra stress on the venous system, extra pressure in there that can cause leaky valve, tortuous veins. Secondary causes, deep veins. This is when deep veins are the cause. Post-thrombotic syndrome can cause this to occur. Someone has a thrombus in the venous system that was treated, it weakened the vein. So you can get varicose veins from that if you had a deep vein thrombosis that had sequelae afterwards. Presentation could be asymptomatic and you visually just see the tortuous varicose veins. It can be painful. They may be like, oh, my feet feel so heavy. I have this dull, aching heaviness. And you may have chronic venous insufficiency. You may have a little bit of swelling associated with that. We diagnose this with ultrasound. On the ultrasound, we're going to look for reflux. So the veins have natural valves to prevent backflow. In varicose veins, because the veins are tortuous and compromised, those valves can pull apart, causing blood flow to go to the other way. So that's what we're looking for on ultrasound. We treat this with compression stockings, sclerotherapy, thermal ablation, or removing the greater saphenous vein if the patient's having severe symptoms or cosmetically really wants this fixed. Deep vein thrombosis, 20 to 30% are going to occur in the calf veins and propagate to the proximal veins. Think Virchow's triad: stasis of blood flow, hypercoagulability, vascular damage. You guys have heard that before, right? That's a big ticket name in PA school, I feel like. The risk factors for this, you guys know: pregnancy, birth control, age over 60, malignancy, prior history of having a DVT, hereditary hypercoagulable state, CHF, obesity, trauma. Anything that causes venous stasis. How this can present: fever, unilateral leg swelling, edema, localized warmth, tenderness, palpable cord, positive Homan sign. We diagnose this with a D-dimer and with an ultrasound with Doppler. Doppler is number one. You can't diagnose this by D-dimer alone. You need the ultrasound. The treatment: full dose anticoagulation and elevate the leg. So what is full dose anticoagulation? What are some medicines? Heparin, warfarin, aspirin is an antiplatelet. So that's more for treating plaque buildup.
Sorry, I mean,
No, go ahead.
I was gonna say, could you do factors 10A inhibitors too?
Yes, absolutely. So Xarelto, Pradaxa, Eliquis, 100%. So those, I always like to ask that because it's like, there's a lot of blood thinners in cardiology, but when we say full dose anticoagulation, it's Lovenox, heparin, factor 10A inhibitors, or warfarin. When we talk about antiplatelet or antithrombotic therapy, that aspirin, Plavix, Brilinta, Effient. Those are like the antiplatelets that we use. So for this, aspirin alone wouldn't treat it. We need the heavy duty stuff.
Would warfarin be like towards the bottom of your picks because it takes longer for it to kick in?
Exactly. For an acute DVT, you can start the factor 10A inhibitors right away. They are usually effective within a few hours. Warfarin, you have to build up the dose until your INR is therapeutic from 2 to 3. So it can take a couple days sometimes. If you want to bridge them to heparin, you can put them on IV heparin until that INR gets to 2, or you can bridge them with Lovenox until the INR gets to 2, and then they can just be on the Coumadin. Great question. Any questions on that? This is the DVT leg. In case I'm losing it. Is everyone losing steam? Okay, superficial thrombophlebitis. This is when This is most commonly caused in like the hospitals when you have an IV in for too long, and it's a superficial vein that gets inflamed. So Staph aureus is the most common cause with IV insertion. The presentation is going to be local erythema. The nurse is going to come in and say, hey, this patient's IV looks like it's warm and red around it. It's going to be maybe a little swollen. It's going to have tenderness at the site. And you also may have like a firm cord, like the vein may feel like a palpable cord on top. We can diagnose this with an ultrasound to check for a clot. The treatment for this is heat, NSAIDs, and take the catheter out. We only really anticoagulate if the saphenous vein is involved or if there's evidence of an infection or an abscess, but typically superficial veins with clots or phlebitis, we don't need to anticoagulate. We don't need full dose anticoagulation. It'll dissolve on its own because it's superficial. PE, I know you guys have seen this 1 million times. This is if a DVT travels to the pulmonary artery. We're going to have shortness of breath, pleuritic chest pain, which is what type of chest pain? When we say like pleurisy. Yes, when you take a deep breath in. Hemoptysis, cough, syncope, bronchospasm, elevated pulmonary artery pressures, and if it's big enough, you may have JVD. The EKG, you could have S1, Q3, T3 on EKG. I have an example of that I'll show you guys. That is not very common to have, but if you see it, your radar goes up. The most common finding in a PE on EKG is tachycardia. It's going to be a fast heart rate. CTA is a test of choice. CTA with PE protocol. So they have to use certain planes to be able to see the PE, even if it's small. The treatment, full dose anticoagulation, like we were talking about with the DVT. If someone can't tolerate, if somebody has a DVT, I probably should have put IVC filter under a DVT. So if somebody has a DVT and they're not a candidate for like a big blood thinner, to prevent it from moving to the heart and causing a PE, you can put in a filter in the inferior vena cava that if the DVT moves up, it'll catch it and it won't go to the heart. So they still have a DVT, but say they have like a DVT and a GI bleed, you can't put them on anticoagulation, but you also want to prevent the PE. You see if they're a candidate for an IVC filter, which is done in the cath lab. They just deploy like a little filter in the vena cava that catches it. If the PE is big enough and meets a certain criteria, you can do an embolectomy to take it out. And this is just an EKG example. You're going to have a deep F in lead 1, a deep T wave in 3, and a T wave inversion in lead 3. So this is not, you may see this in other people that don't have a PE, but if PE is on your radar and you see those signs, your red flag is going to go up. And that's all I have for you guys. Any other questions?
Thank you.
You're welcome. Have a great weekend.